Welcome to this morning's discussion on Psyfeld, the Raincoats. Just a quick note. I know this is a two-part episode. I only really assigned episode one. However, if you have watched both episodes and you want to discuss behavior observed in the second episode, that is not off the table. All right. So if there's an opportunity to teach with regard to something you saw, that's quite all right if you're speaking to the Raincoats part two. So with that, let's kick it off. What did you see in the episode that was of interest to you? Where do you want to start?
Something I noticed was Jerry's obsession with pleasing Elaine, and this kind of fixation he had on it. I know that's like the whole joke of every episode is that Jerry's fixed on something and like it puts them in ridiculous situations. But even when she brought some reasonable, ideas to him saying that it would hamper their friendship, he still felt like he needed to compensate to be, I don't know, like more of a man or something.
So let's talk a little bit about Jerry's behavior. You mentioned that this seems to be recurrent in every episode. And
are you with us today? Or
one of the things that you have to consider here is that this might be a chronic illness, and that chronic illness may be either axis 1 or axis 2 pathology. This would differ from those mental disorders that are otherwise classified as episodic, which even though they may reoccur, usually have a relative short duration. So given the nature that this looks to be a chronic disorder, it does help us with regard to narrowing our differential somewhat. So with that in mind, and with your observation about his obsession, we should first probably talk about what an obsession is. An obsession is a deficit in thought content being one part of the comprehensive mental status examination. So in any patient you evaluate, whether that patient is someone you rotate on in psychiatry or outside of psychiatry, surgery, internal medicine, the mental status examination is a routine part of the neurologic exam, right? So cerebellar testing, deep tendon reflexes, mental status exam. As part of the routine neurologic exam, the mental status assessment has several components. And in your PowerPoint, those components were reviewed through an acronym, ABC, STAMP liquor. And thought, the T in STAMP, has many parts, many examples, one of which happens to be thought content, one deficit of which is an obsession. So that is a background in terms of where it is, pardon the pun, in your mind, you should envision this deficit. The next step is understanding more about the obsessive thought, that obsessive deficit in thought content. Obsessions are intrusive thoughts. And there are intrusive thoughts that when used in clinical psychology and psychiatry, impair functioning in some way. Obsessions run a continuum. You should know that the overvalued idea is another deficit in thought content, but it's a mild form. And as such, we usually operationalize mild as not being clinically significant. On the other end of the spectrum, there is the delusion. This is another abnormal thought. This is another deficit in thought content, but it's considered to be more severe than the obsession. And that severity is characterized by it remaining fixed, meaning that the individual persists in their belief, even when presented evidence to the contrary. So the nature of thought content may run a continuum from the overvalued idea, which is not clinically significant, to the delusion, which is clinically significant as well as fixed. Somewhere in the middle is the obsession. If Jerry is obsessed, and if Jerry's obsession seems to not only be stable, that is, he demonstrates it in other episodes, prior episodes, as well as future episodes, it is clinically significant, and it's also pervasive. Again, we're going to have to cheat a little bit here. Outside of this plot summary, we see this type of thought, this thought content demonstrated in Jerry Seinfeld, the character, towards people other than Elaine. So it's also pervasive with regard to setting. It's not only Elaine. This is not a Jerry and Elaine thing. And as soon as we understand that, and as soon as we understand now what an obsession is and what it might mean, now we can begin thinking of different disorders that Jerry may be diagnosed with if he were to present to clinical practice. Obviously, the very first one that would pop in our mind, again, pun unintended, would be what?
Maybe like obsessive compulsive personality disorder.
Possibly. Certainly the obsessive compulsive personality would most definitely fit the clinically significant criterion, as well as being stable and pervasive. No doubt about that. What else is the differential? Obsessive compulsive disorder, right? OCD. OCD is defined through obsessions that are clinically significant. It's that easy. And Jerry fits that easy. Of course, the other part of it also rings true, meaning that if Jerry were to not demonstrate obsessions, but instead demonstrate compulsive acts, rituals, hand washing, that also rise to the level of clinical significance, he still rules in for OCD. And of course, if he presents with both obsessions and compulsions that are clinically significant, OCD. So one, the other, or both. That must be our differential as well. Because of the incidence of obsessive compulsive personality in OCD, the lines are a little bit blurred with regard to these two conditions. Again, remember, both are clinically significant. So don't let the fact that OCPD, the personality disorder, having been previously categorized on axis 2, lead you to believe that it is any less serious than the axis 1 pathology of OCD. In both cases, people may actually demonstrate obsessions and have those thoughts. So sometimes it's not that straightforward to tease this away. What the clinician must look at here for Jerry is whether or not the DSM criteria for obsessive compulsive personality are in fact met. Is Jerry a perfectionist? Does he need order and control? Because if he is, many of us would identify that as the type A personality, and that is synonymous with OCPD. In the absence of those behaviors, in the absence of those personality traits, obsessions, compulsions, or obsessions and compulsions define OCD. Right, so make that differentiation. Anything else going on here with Jerry? What about his interaction with Elaine beyond the obsessions? How does it end for them?
Sexual dissatisfaction.
So, sexual dissatisfaction, to say the least. Yep. So Jerry presents to you with a chief complaint of sexual dissatisfaction. Again, you're gonna provide a history and physical. And you see that this is not a Jerry and Elaine problem, right? So we're not going to shrug our shoulders as physicians and say, well, what type of disorder might this be?
Erectile dysfunction.
Yeah, right. Erectile dysfunction or broader category, sexual dysfunction. You should know that up until 2013, the American Psychiatric Association categorized 3 different types, subchapters of sexual disorders. In 2013, with the revision to the DSM-5, that changed a little bit, in which each became its own chapter, the sexual dysfunctions being one of those chapters. Does anybody know what the other 2 chapters are? The sexual deviancies, otherwise known as the paraphilias. And then the final one is gender dysphoria. When an individual has conflict and dysphoria due to the mismatch between their assigned sex at birth and their experienced gender dysphoria. So again, there are 3 separate chapters that were once known as the sexual disorders. All right, anything else with Jerry? Any other observations with regard to Jerry Seinfeld?
Well, I wanted to ask a question. As a psychiatrist seeing a patient with ED, I know, sildenafil is the common route to go through things, but I was wondering if there were, if they also provide something like cognitive behavioral therapy for performance anxiety, which I think is the case for Jerry, because it seems like he's able to perform sexually or satisfy other women, but with Elaine, there seems to be an issue, and I think that's why it affects him so much.
Good question. So with Elaine and with Jerry's erectile dysfunction, a routine part in the history and the assessment would be his behavior with other sexual partners. And if there are no problems, I think treatment planning would go one way. However, if there is a problem that is pervasive, treatment planning would go yet another way. For this condition, if in fact erectile dysfunction is the single best diagnosis, and we're led to believe there's a co-occurring illness, an anxiety disorder, not only would you focus on the erectile dysfunction with regard to a biopsychosocial treatment plan, but you would also come up with a biopsychosocial treatment plan to address the co-occurring anxiety disorder as well. And that co-occurring anxiety disorder may be social anxiety disorder, right? So well, let's start from scratch. What is social anxiety disorder? Social anxiety disorder is clinically significant anxiety with regard to, again, it's pretty much straightforward, social or performance situations. Okay. So if that is the case, one of the things I would want to ask Jerry is beyond sex. Are you experiencing, remember he's a comedian, are you experiencing any anxiety when you get up on the stage? Because the answer is yes. The idea of social anxiety disorder is strengthened. It would be higher in the differential diagnosis, especially since he almost has the perfect vocation, career to assess for that. A lot of people may not routinely put themselves in situations in which they're performing. Because performance anxiety is one of the most common forms of social anxiety, the DSM-5, the most recent revision, had created specifiers. So social anxiety disorder performance subtype is now a diagnosis, and many of us just refer to that as performance anxiety. Right? So on your shelf exam, you may see social anxiety disorder performance subtype. That is let's say that is the case for Jerry, and let's say you are putting together this treatment plan. Psychosocially, you're going to refer him to therapy. In therapy, I would suggest that the psychotherapist address not only the social anxiety disorder, but in addition, the erectile dysfunction. So I think I'm not sure he would actually need two separate referrals for that. He might, but I would certainly make a single referral in the beginning. From your perspective as a prescriber, social anxiety disorder, what can you also consider?
I was gonna ask if, because I know for anxiety disorders, typically chronic treatment is with SSRIs, but that has a side effect of low libido or sometimes erectile dysfunction. So I guess I would ask if a person was given Viagra in tandem with SSRIs, if that would counteract that side effect.
That's a good point. And there's potential there. There definitely is potential there. That is, if you're going to address the erectile dysfunction as well, biopsychosocially, a medication, a tumescent, in combination with a psychotropic medication to address the social anxiety, may be a combination. And if you were to prescribe these, which medication would you be concerned about Jerry Seinfeld telling you he's being prescribed by his PCP for performance anxiety on the stage? So let's say he endorses that, which again strengthens your provisional of social anxiety disorder performance subtype. And he tells you, I only take one medication. It's for performance anxiety prior to my act, prescribed through my primary care. Which medication interaction would you be concerned about here?
Would it be beta blocker?
Yeah, beta blocker and Viagra would be very concerning and could lead to orthostatic hypotension, decreased cardiac reserve, and acute MI. So you gotta be very careful. So what's another option with regard to, let's say you give this a trial, and let's say the drug combination of the tumescent plus the SSRI doesn't work. Are there any other options with regard to monotherapy for his social anxiety disorder that may not have as bad a side effect with regard to his erectile dysfunction?
Bupropion.
Bupropion. Now, what psychiatrists usually do is they will add bupropion to the SSRI. Many believe that the sexual side effects of the SSRIs are due not only to the increase in serotonin, but the increase of serotonin relative to norepinephrine dopamine. So low dose bupropion, which is an norepinephrine dopamine reuptake inhibitor, may reestablish that equilibrium and may overcome those sexual side effects. So whether you keep the Viagra on or discontinue it, adding the NDRI, bupropion, is an option. Let's say hypothetically it doesn't work, and your patient tells you, I don't like being on 3 drugs, doc. I already take that beta blocker. 4 drugs? Can you just give me 1 drug? What's a second line therapy for social anxiety disorder once you discontinue the SSRI? And if you discontinue the SSRI, you're no longer going to need the bupropion.
I don't know if this is the second line therapy, but I know in acute settings we give benzodiazepines.
You could give benzodiazepines in acute settings. Remember, while that might be okay, 30 minutes prior to his act, certainly you'd be a little concerned about the drug interaction with the beta blocker. So maybe try one or the other. But if he's telling you the beta blocker is working just fine, I'm not sure I would change that. I don't know about taking a benzodiazepine prior to coitus. That one, I'm not sure that's routinely done. The medication class that you should consider here for social anxiety disorder is actually the MAOI. It's a third line agent because of side effects. But they are FDA approved for social anxiety disorder. And the way this comes up on your test, on your either your final exam or your clerkship shelf exam, is an individual who, and make sure you remember this, number one has an indication for use. Now, that seems incredibly obvious that the vignette would paint an indication. The caveat here is that there's a 50-50 chance that that clinical vignette paints a scenario other than major depressive disorder. So you have to respect that a lot of these medications, tricyclics, second line agents, and the MAOIs, third line agents, have alternative indications per the FDA. And you're gonna have to know them, right? Because it's a 50-50 coin flip, whether you're gonna get one of those options versus major depression. Once you understand that, the second part seems just as intuitive. There should be an absence of contraindications, right? So sometimes, 40% of the time, no, we'll make this 50-50 too. You will be giving something discrete in your clinical vignette that will allow you to say that the MAOI, this third line agent, has a relative contraindication, right? We're very straightforward. On the other hand, you may miss that information and you have to deduce whether or not this patient has a health-related problem that should cause you concern. In the absence of discrete information, there are two demographics test takers should routinely investigate that will allow them to say, this patient is a candidate versus this patient is not a candidate. Number one is age. And someone who is young, without any explicit evidence of general medical condition, the test taker may assume health, right? So the absence of any discrete information about one's past medical history in a 21-year-old connotates, personifies health. Of course, the direct opposite is false. That is, someone who is older must be considered to be medically complicated, even if their past history, their past medical history is not provided discreetly in your clinical vignette. So while a 21-year-old missing that information may be prescribed the third line agent, MAOI, a 71-year-old should not, even if there is no discrete information saying he or she is sick. Number two, the other demographic is sex. Females are healthier than males. So the gold standard for health on a shelf exam is a young female, right? With no information provided, a young female is the epitome of health, and the opposite that is also true in the reverse direction. The epitome of illness is the older male, even without any discrete information that he has any medical comorbidity. Now, there's two intermediates, of course. There's the older female and there's the younger male. And certainly the older female would be the next concern, the younger male being more towards the healthy side. And we could talk about different clinical scenarios in which those intermediates might pop up their head, right? But that's what you have to look at with regard to prescribing the MAOI. Number three in the clinical vignette is that safer alternatives, first-line agents, have been given therapeutic trials, but have been unsuccessful. And that's the exact scenario that I just painted you, telling you that the SSRI Viagra combination doesn't work. You might want to give it another try with an alternative SSRI. And when you fail two trials on your test, you are safe in picking either the second-line agent, TCA, or the third-line agent, the MAOI. Off the top of my head, I do not think any TCAs have any FDA approval for social anxiety disorder. The MAOIs do. And that's the thought processing with regard to choosing the single best answer pertaining to Jerry's sexual disorder, specifically a sexual dysfunction. Any questions about that? Any other characters you want to discuss this morning?
Yeah, Elaine. So she says that, like, she's joking with other women about faking orgasms, and that could be like her normal. But if it was like a decrease from baseline, it could be a similar thing where she's having like an arousal disorder or an orgasmic disorder or something like that.
Yeah, so I mean, we could look at sexual disorders through Elaine's character as well. What I will say with regard to the sexual disorders pertaining to Elaine and or Jerry, when you're studying for your exam, I would take your favorite board review book, and in front of your laptop or iPad, I would Google sexual response cycle images, bring up that image, and what you'll notice is that for every step in the sexual response cycle, there will be at least one attached sexual dysfunction. And whether you have Elaine in mind or whether you have Jerry Seinfeld in mind, it is really easy to review for the shelf exam when you have your favorite board review text with that visual image, connecting the DSM diagnoses to those different phases, each phase of the sexual response cycle. Any other thoughts with regard to the Raincoats? Well, in closing, I wanted to bring up a loose association. And again, this may have come in, I think, did anybody get to see the Raincoats Part 2? So not, and that's good, because I specifically said one. But something did come up, and I just want to briefly review this because it does link to how we started. So it's great. I want the last 3 to 5 minutes, I want to end on a similar note. Remember, we started this with the idea that Jerry Seinfeld is struggling with clinically significant obsessions. Again, obsessions are deficits of thought content. Another example of a deficit in thought content, albeit a more severe form, is the delusion, the fixed belief. Obsessions are not fixed. Overvalued ideas are not fixed. This most severe form of thought content with regard to deficit is the delusion. And delusions, if they recur and are clinically significant, might allow a clinician to formulate delusional disorder. It's that simple. Individuals who struggle with one or more delusions that are clinically impairing have delusional disorder if their delusions are not in the context of a broader mental illness, such as schizophrenia. That's basically delusional disorder. And one of the differentiating ways to look at delusional disorder versus schizophrenia is that if it were not for the impact of the delusion itself, and again, it is clinically significant, but if not for the impact of the delusion, the individual would actually be functioning normally. You can't say the same for schizophrenia. Schizophrenia is a chronic disorder that also has severe cognitive deficits. And it's that differentiation that usually allows the clinician to differentiate one from the other. Delusional disorder has subtypes. When we get to rounds today, we will review those subtypes. One of the subtypes is undifferentiated. And anytime learners hear that, they know what's coming. It's basically a grab bag category for all those other subtypes that can't fit in to the original list because they're relatively rare. So you'll often hear clinicians talk about them as rare psychotic disorders, and they are just that. And one happens to be the Paris syndrome. And I just couldn't help but think that because the second part of the Raincoats actually, I'm going to say is set in Paris per se, but certainly has Paris in the script. So it prompted me to think of these other rare conditions, and I just want to briefly review them so that when we round today and we review the subtypes of delusional disorder, we can leave the undifferentiated subtype off our table, having discussed them now. There are some, like the Paris syndrome, that may come up on exams. If you want to review them, I posted the link, very brief description of them on Twitter. I think that went out. I think that was posted yesterday. But for now, let's go through a couple of them that tend to show up on shelf exams. So number one is Capgras, otherwise known as Capgras, if you're going to pronounce it right. What is Capgras syndrome? In as much as it might be an undifferentiated subtype of delusional disorder.
Is it the belief that somebody else is in like a loved one's, like someone has replaced a person you know?
That's right. I think of it as the body snatcher syndrome. The body snatcher syndrome. So if you've ever seen Invasion of the Body Snatchers, only because it actually has that name in the title, but quite frankly, it's almost every alien film. Even Men in Black, even if you don't want to go horror, and you want to go comedy, that is Capra, right? The delusional belief that an imposter has taken over a loved one, and it's usually somebody who's close to the index case, their spouse, their mother, their father. Okay, Cotard. What's the Cotard syndrome? Another undifferentiated subtype of delusional disorder. Cotard is the delusional belief that one's self, whether physical self or emotional self, is dying in some way. Okay, Cotard. Okay, or dying or missing. So this is the Wizard of Oz, Cotard syndrome. If we remember that Dorothy Gale goes down the yellow brick road, incident to having that window pane fall on her head, and that everything she sees may be a psychotic process secondary to traumatic brain injury, we actually get some insight with regard to that traumatic process. That is, psychotic process. And that is, she meets characters along the way that are extensions of herself. One is missing a heart, one is missing a brain, and one is missing courage. And that's Cotard, right? So in a strange twist, The Wizard of Oz is, I think, a fictional case of Cotard syndrome, secondary to traumatic brain injury. In this case, the syndrome is not part of a delusional disorder, undifferentiated, nor is it a syndrome within a broader psychotic illness like schizophrenia. Instead, it's psychosis due to general medical conditions, specifically TBI. Right. Cotard. And then the last one that we usually see, there's several, trust me, there's over a dozen of these, but the third most common is called Fragoli syndrome. Any guesses of what Fragoli syndrome is? Fragoli syndrome is the delusional belief that a person can change shapes. So not that an imposter has taken over a loved one, but instead that a single person can change shapes. This is the shape shifter syndrome. It's hard to say at 8:30 in the morning. Shapeshifter syndrome. That's Fragoli. That's the Matrix. Anybody seen the Matrix? We know that Neo likely has a form of psychosis, and that within his psychosis, he struggles with the Fragoli syndrome, this delusional belief that the agents can change shape, shapeshifter syndrome. That's also Pennywise, the dancing clown, right? Stephen King's interdimensional predator and shapeshifter from his novel adapted to film, It, right? Shapeshifter. So those are some examples of rare psychotic syndromes. There are others, but I think if one's going to appear on your test, there's at least an 80% chance that the one that's going to appear on your test, is either Fragoli, Capgras, or Cotard. They're the most common. Any final questions? All right, that'll be it for this morning. Thank you, and I will be meeting up with our team around at about 9:30 today. Thank you.
Thank you.